Hello, and welcome to the Care Machine Sustainable Healthcare Podcast. I'm your host, Professor Helen Mees. For all the concerns over patient care and service provision in the NHS, the one area that often gets totally overlooked by politicians and the public alike is the healthcare system's vast acreage. The NHS has more than 13,500 buildings across 29 million square metres of estate, 50% of which is owned by the hospitals themselves, and the rest being managed by organisations like NHS Property Services. And what does that mean in terms of energy? Well, the NHS is the UK's largest single public energy user. During the last survey by the Estates Return Information Collection in 2019-2020, the estates reportedly consumed over 11.3 billion kilowatt hours of electricity, with hospitals using a whopping 20,000 to 45,000 kilowatt hours per bed annually. That's 10 times the energy use of an average household in the UK. And with that consumption comes an annual energy bill of over £1.4 billion a year. So the big question is, what are engineers doing to reduce this energy use and the associated carbon emissions whilst protecting reliability, affordability and the everyday medical services that patients require and staff experience on the ward? Well, there is progress worth recognising. Estates emissions have been reduced by around 10% since 2019-2020, and the electricity-related emissions are falling as the grid decarbonises and on-site renewables and sustainable practices within hospitals expand. But this still raises many questions. Do we treat estates as an inevitable fixed cost of providing healthcare to society, or as one of the biggest levers we have to improve patient outcomes, cut clinical risk and reduce emissions at scale? My guest today is Dr. Nora Vudka, a social anthropologist, architectural engineer and artist. She holds a degree in architecture from the Technical University of Munich and went on to complete an MA in social anthropology of development at SOAS in 2010, receiving her PhD in social anthropology at SOAS in 2024. Nora spent 10 years in China and Myanmar while working for local and international architecture firms based out of Shanghai, including 2.5 years as project architect for David Chipperfield Architects. In 2015, Nora moved to Yangon to work for Article 25, a London-based NGO, on the reinvigoration of Yangon General Hospital and development of the master plan for the hospital campus. Currently, Nora is a postdoctoral researcher at Durham University and a research associate at SOAS. I began by asking Nora to share her story from architect to anthropologist to healthcare and what led her to focus on healthcare buildings and their sustainability. Nora, thank you so much for joining me on today's podcast. I'm really excited to talk to you because I know you and I have known each other for a little while now up at Durham, but I'm really interested to get your take on sustainability, particularly from this kind of point of view. So I wanted to start by setting the scene for our viewers in terms of your career, but like many of us who have kind of ended up in the healthcare sector, you've had somewhat of a circuitous route, haven't you, into the healthcare sector. So how did you get from training as an architect into healthcare, and what led you to a research career that focuses on sustainability?
So you're right. It's quite a winding journey. I studied architecture in Germany first for 6 years, and then felt that I was missing the people in my studies and in my understanding of buildings and kind of like engineering of buildings. So I came back to a plan I had before my A levels, which was to go to SOAS at the university in London and study social anthropology. So that's what I did. I did a master's in social anthropology of development at the time and left university kind of right when, yeah, everything went down business-wise and nobody had jobs, and went back into architecture and went back to an old company that I had worked for previously and started pretty quickly working as project architect on large master plans in China. And as I was thinking, I shouldn't be doing this work because I've never been to China, they sent me to Shanghai, where I worked for, yeah, nearly, yeah, well, I was there for nearly 5 years and worked for David Chipperfield Architects, doing a lot of cultural buildings, actually not hospitals, museums, and so on. And then decided I needed a change and applied with Article 25, an architectural charity based in London. The name is based on the Article 25 in the Charter for Human Rights. And they pretty much from Shanghai sent me to Yangon in Myanmar, where I arrived in 2015, just before the elections, where Aung San Suu Kyi was elected. And I stayed there until for first renovating, or it was called the Rejuvenation Project for Yangon General Hospital, starting with supporting the renovation of the colonial buildings on campus. It's a huge hospital, it's 2,000 beds and more. And then we were asked to develop a master plan. So I spent a few years on developing the master plan for Yangon General Hospital before yet again returning to SOAS and academia to write my PhD about this particular hospital. And that then I finished my fieldwork in Myanmar just before the military coup in 2021. So at the end of 2020, I left Yangon, which was really devastating because Yangon General Hospital had a lot of doctors who were supporting the civil disobedience movement, and yeah, so that was a very particular time. And I finished my PhD in London and then joined the Durham Engineering Department as their only social anthropologist, working in the thermal node, looking at energy systems, and yet again landed in a hospital in the northeast of the UK to look at energy system at their energy system and potential renewable alternatives.
It's such a roundabout route, but actually has always drawn you back to that healthcare kind of theme, hasn't it? Which it must have been very exciting. I know I want to come on to the work that you've done in Southeast Asia and so on, but I wanted, because today's episode is all about healthcare buildings and infrastructure, I wanted to start by kind of just setting the scene, I think, for our viewers. So for those of you that are unaware of the sheer size of the UK NHS estate, it is, according to NHS England, the largest landowner in the UK with over 29 million square metres. That's 7,166 acres, or the equivalent of 3,500 soccer pitches. Of course, that's the unit of measure, in size. And it costs more than £10 billion a year to maintain. That covers everything from the hospital buildings and the internal services like heating, electrics, plumbing, and the clinical gases, as well as the surrounding landscape and public services. They even get involved with town planning and property development, which I know Nora has some kind of knowledge of, working in Myanmar. So really, the NHS estate is a business within a business. So what are some of the key challenges, do you think, Nora, that are facing hospital infrastructure from your experiences out in Southeast Asia to looking at the UK today? How does that affect the services that hospitals provide?
So I think it is really interesting to work with an existing estate and to keep a hospital, an acute hospital running while actually also being um, a set of buildings and infrastructures that are also have their own kind of like material metabolisms. They degrade, materials fail. So to kind of keep this estate running while keeping operating as well is really a key a challenge for many of the estates teams. And at the same time, our climate is changing, our world is changing, our fuel sources are changing, and how to kind of integrate this with often quite old buildings. It was fascinating to see how in Yangon, for example, the oldest buildings performed pretty well over time. So they were not necessarily the most specialized buildings where the intensive care unit is in or where specialist operating theaters are in. But for example, the main building that was built around 1900 was the building that they used for the COVID wards at the time because it was the best ventilated building. It had big windows, it had big openings that could be mobilized, and the layout of the building kind of worked together with this like fast moving emergency at the time. I was actually on campus as the first COVID wave um, evolved in Myanmar. So that was really interesting to see, and how, in a way, the energy system, so the light, the ventilation of those historic buildings was quite functional for in that moment. And in a similar vein, it is interesting to see how kind of those uh, this changing environment that we are in, how in the UK estates are trying to or need to adapt to that. So um, different needs around cooling, for example, that heat waves are rising, but also thinking about how to keep buildings warm. Um, and that is quite a challenge, and to make a decision also on what kind of fuel sources to use. So
Yeah.
to put solar on the roof or to rely on other renewables maybe coming into the site. And yeah, but this fast changing environment that we are in isn't always fully lined up with policy, like healthcare building notes, and so on. So um, how to work within the existing policy frameworks while also responding to constantly evolving needs of the clinical services, of the patients. Our health conditions are changing at the same time as well. And I think the third point is really, which is a great challenge, and which I didn't quite anticipate as much. I did see at Yangon General Hospital the question of backup quite a lot. So, what happens if the
Mm.
grid goes down? And in Yangon, that was something that would happen much more regularly. And the clinical teams were used to that. So, okay, the power goes down, the electricity goes down. Somebody first of all blocks the doors to the operating theater, so nobody gets kind of like locked in. And then it's a call to the estates team. How long is this power cut going to last? And of course, they have UPS backup and batteries, and then the generators are kicking in, and it's all of that. I hadn't quite anticipated this as much, having that many discussions around backup and resilience in a UK hospital, but it is often the backup capacity that ties in with what services can be provided on a day-to-day basis. So not to add too much energy or electrical capacity to the grid that can then not be provided should something go down, so to say.
It's really interesting as well as you're talking about that. I'm thinking, actually, that's something that we don't even think about here in the UK, right? Or indeed in the West. We don't think about losing power in the midst of doing a major piece of surgery. The electrics are always on. And I suppose there's quite a lot to learn from that sort of experience as to how do you manage in those kind of conditions, and how do you set your hospital up differently to be able to do that. It's quite interesting how you were able to witness that in real time, seeing a country who were used to power going on and off, and had developed ways to get around that to ensure that patients were kept safe. It's really fascinating.
Yeah, I think the point is the length of, for example, a power cut. So all um, vital machines have backup batteries, so they can last for quite a while. But what happens if it's a day and we need to
Yeah.
rely on generators? If it's a week, what happens? What happens down the line? It is really fascinating to have seen and having had discussions, for example, with the forensics department at Yangon General Hospital around DNA research. And they said, well, we have the DNA and we have the knowledge how to do it, but the cooling chains prevent us to do certain bits of research. Or they're also like we are quite reliant on electricity. And that was something which is very important to think alongside the buildings, the services, the people, and all together.
Yeah. And I remember us talking some time ago actually, and you said that about the structure of the buildings, whereas the UK hospitals tend to have very large grounds, so they tend to be sort of low level, maybe one or two stories, but quite sort of spread out. And I think you once mentioned to me about the hospitals being multiple stories and therefore completely different way of managing the structure of the building.
Yeah, completely. I mean, it is really interesting how hospital design also changed alongside construction methods. So, with the advent of reinforced concrete, we started building towers, and that is a different way of thinking about disease, about bodies, and how bodies and disease move through buildings
Yeah.
together.
So do you think then, from obviously your years working in China and Myanmar, do you think that there were differences that stood out to you that the UK might learn from in terms of building new health facilities? I'm thinking particularly of constructing new hospitals here in the UK. Do you think we could learn anything from what China and Myanmar are doing with their hospital infrastructure, particularly around sustainability, I guess?
There is a history to hospitals in Myanmar, which is a colonial history. So the way, for example, Yangon General Hospital was built originally was by the empire at the time. Well, the British Raj, and later Myanmar then became independent. But so there was a lot exported in the way in the way this hospital specifically was built, but also other hospitals around the country. I think there's a lot to be learned around climate design, but also with caution and with an awareness of kind of the colonial histories that surround
Yeah.
architectures today, and understandings of heat, of humidity, and so on, and how that is talked about. So I think there is a lot to be considered around all of this. A big part of my doctoral thesis was really spending time on campus, so at Yangon General Hospital. So as social anthropologists, we do participant observation and field work. And I particularly, given my background as an architect, I use drawing as a methodology. So I spent, and I did the same at the hospital in the Northeast. I spent days and nights sitting on campus or sitting in an operating theater sketching instead of writing my field notes, which creates a which usually creates a very positive engagement with the people around me in the hospital. So I'm not necessarily seen as somebody who's auditing, but more kind of like the kooky artist. What are you doing here? And then I can start conversations with people. Um, but what this methodology and very careful ethnographic research showed me was the importance of the spaces in between buildings and bailiwicks. So between kind of like the building structures, but also between the institutional structures, between the shift patterns, between the job descriptions, all the kind of work that is going on in between, so to say. Um,
Mm.
in in um, in Yangon, it is maybe a little bit more in terms of what the family is taking over, creating this infrastructure of comfort, infrastructure of care, where it is really the family members who are very, very involved in, for example, washing patients and caring for them, bringing them food, um, taking care that the bedding is comfortable, and so on, fetching medicine. So there's this like reliance on kind of like a wider care system in a sense.
Yeah.
But there is something similar that can be that I can see in hospitals in the UK as well, where family members are really important, but what are the spaces that are being provided for them? And I think this ties in with sustainability questions as well, because sustainability isn't only technical, and it's not a technical problem. It's not a play problem. Like we can't just um, put put I don't know, a particular technology into the energy system and then it works. It is very much about using it. How is it used? How the process is working, and things are also changing. So things might then also change in the clinical services for the better, because now suddenly we have maybe a different capacity in on the grid or something like that.
Yeah, I think you've answered a question that I was really keen to sort of come to in terms of the issues of implementing sustainability in hospitals, particularly looking through your dual lenses of architecture and anthropology. Are there some challenges, major challenges that you think are facing health care providers in implementing sustainable practices or strategies into their sort of estates management programs? Are you seeing anything through that, being able to draw out those images that we perhaps wouldn't capture if we were using other methods to look at how we implement sustainability?
I think a big part is really this question of backup and resilience in our in our um, in our healthcare systems. And I think there is a lot of talk around investing into healthcare systems, and that a hospital is an investment, for example. But I think we should
Yeah.
reframe and understand our healthcare system as an insurance, rather than an investment. And I think that is something to really consider very carefully. And um, also, to understand that things can change and have always changed. I think I come across often when I say I'm looking at the energy system or at energy savings or possibilities of energy demand reduction, which is a really big thing. Demand reduction, I mean, is possible, because the way, for example, air conditioning has been become so prevalent in hospitals was also a development. So we can think, if we think, for example, carbon reduction in tandem with patient well-being, or decarbonization in tandem with patient well-being, I think we will come up with great solutions. I think that a lot of times those are thought in silos and separate from each
Yeah.
other. But yeah, so I think that's a key point. And when I was talking to estate managers who worked on hospital estates for a very long time, one point that often came up was, well, we are powering up diesel generators every week, every other week, once a month, um, which is just not sustainable, so to say. That's not going to lead us to net zero. But what steps do we need to take? So kind of like when push comes to shove, and everything just needs to work, especially, let's say, mass power outage, or I don't know, mass event, whatever that's going to be. Hospitals are the first port of call, so
Mm.
they really need to work. So thinking that through very carefully, I think is a big challenge in that sense, because a hospital does need to work at the end of the day, and it shouldn't be competing priorities between saving lives and saving the climate. They can go hand in hand, and they need to go hand in
Yeah.
hand.
So that leads me nicely on actually to my next question about mitigation then. So what kind of actions are hospital estates undertaking to mitigate some of their carbon footprint? You talked there about diesel generators. And how are other countries, from your experience, how are they tackling those same sort of issues?
Yeah, I think one part is, um, for funders of academic research, which is kind of like the um, early kind of understanding what questions we need to ask, to really rethink what is evidence, and what kind of research are we commissioning that then allows estate managers, for example, or clinicians to make different decisions. So I think we need to see a move towards qualitative research, because numbers can tell us problems and priorities, but they don't really tell us the why behind the story. Why is something the
Yeah.
case? And I do work in an engineering department. I do work with very, very like with fantastic colleagues, who work on really fascinating technologies. Well, why are they not implemented? And those are not technical questions; those are political and social questions and economic
Yeah.
questions, and they tie in with each other. So I really think, it is thinking patient well-being together with sustainability, because they don't cancel each other out.
Yeah, I would totally agree with that. I mean, the first thing that comes to my mind is a systems engineering approach, right? Is you cannot make a change, a technical change, without affecting other areas of the system in different ways. And at the end of the day, we're dealing with patients, right? We're not just dealing with a machine that you can tweak a few bolts and it's fine. But hey, every patient is different. So we have to have them at the forefront of any change that we make, whether that be sort of technical, I guess, or political or structural. It always has to come down to them. So the mitigation really is around them, isn't it, at the end of the day?
Yes, and their experiences of the healthcare system,
Yeah.
and the way they are experiencing them. There could probably be quite a lot to be done around patient pathways and scheduling, which would make patients' lives a lot better, but also improve the energy system and how energy is used at the hospital, for example.
Yeah. Yeah. And transport as well, because we are now dealing much more with multiple morbidities in patients, them having to make multiple journeys to have different appointments in different parts of the hospital, when we could be thinking more holistically about how to treat their conditions by bringing them into the hospital maybe once or twice rather than 5 or 6 times, and adding to that carbon footprint of travel, right?
Exactly. And here the kind of like qualitative research and very careful ethnographic research of like really spending time on hospital as a researcher myself comes in as well. Like I know how comfortable or uncomfortable waiting room chairs are, really, because I am sitting there the same way. I know how cold an operating suite can feel at 2 or 3 in the morning, even though objectively the temperature hasn't changed necessarily, but because the way I'm moving has changed because I'm sitting more at night or I am not running around as much or the light has changed, which affects thermal comfort as well. So really under this, and this comes back to what I said earlier around the spaces in between. If we are then changing, scheduling or appointments and have more coordinated appointments, what does this then mean on the ground if somebody is then spending longer time, for example, in the entire building, maybe moving from place to place? But are there maybe other bits and pieces that then need to be changed or altered uh, alongside all of this? So
Yeah.
it's really having this kind of like view and thinking very carefully through the practices that are being done throughout the day for both staff and patients.
Yeah, I think as well, you hit on a very good point. We often don't think about the staff's use of the building either, do we? We do obviously want to focus on patient, but the movement and the use of the building and the estate itself that the staff have to go through, the distances they have to travel across the buildings can be pretty vast. I mean, I dread to think most of them must be walking a marathon a day in some cases.
Yes, and it is staff that stays in the same buildings for decades at a time. In Yangon, we worked very closely with a healthcare planner, and we had a lot of conversations around distances between beds. And there are best practice, and they slightly differ from, let's say, from US to Singapore to the UK. But we calculated if we would create kind of like the absolute considered best practice. I mean, that's also often a question. What is best practice for who, when, and how? But if we would have created even bigger bed spaces, the nurses, they are not it's just they're not enough nurses. They wouldn't have been able to actually cross those distances, for example. So to really
Yeah.
thinking through what that what even small decisions like a few centimeters in terms of bed space mean. Um, and in a similar way, a hospital ward might have enough bathrooms, but um, are they really located in the best way? Like, yes, they might be to standard, but what does it really mean if you are in this particular corner of the ward? For example, that was another question, another discussion that came up at one point when we were doing the master plan for Yangon General Hospital. And yes, it is staff that spends a considerable amount of time in those buildings. So how are they experiencing the buildings as well is incredibly important.
Yeah, yeah, absolutely. Now, I'd like to sort of think about the future maybe a little bit now. So, the NHS's net zero strategy seems to be making good progress so far. They are
Mhm.
having some significant impact. It's very well adopted now across many of the hospitals in the UK. But what are your thoughts on it reaching its goal of net zero by 2040? I mean, we're really not that far away. Do you think it can be achieved in light of the fact that infrastructure takes up 66% of the overall carbon footprint of the NHS? Do you think we've got a chance of reaching that net zero goal?
Ooh, I think we are on a good path towards something better. Um, I'm not a numbers person. So I couldn't say really, I don't know, 66% of carbon footprint versus, and then we have, I don't know, 14, 16, 14 years to go. I, and, and it's, I mean, the world is unpredictable. So
Oh,
I couldn't quite say, but I do think that there are an awful lot of people who are doing incredible work throughout the NHS to decarbonize the system. And I do think that I'm hopeful that we are on a good path in that sense. So and it is often small improvements that then lead to kind of like a bigger movement. And I can see an awful lot small improvements around me.
yeah.
So yes, I guess that's
So we can be
my
hopeful then, can't
prediction.
we? I think that they're on a good path.
It-
Whether they'll reach that, that's particularly around the buildings, I suppose, is always going to be questionable. But as you rightly said, those little changes that can be made, even just the distance between a bed, can make all the difference in terms of reducing the carbon footprint of the hospital building. So you never know, we might get there.
yes, and small decisions around thermal comfort, around rethinking one thing at a time can make a difference. Yeah.
Yeah, definitely. In light of that, what would you suggest to our viewers to take away in terms of some of the ideas around thinking about the estates within a hospital, whether you're a member of staff, whether you're a patient, from your own personal perspective, uh, what actions or strategies do you think you could share that maybe could help us think a little bit more sustainably when it comes to our buildings within the NHS?
So, well, I have this very particular focus on energy working in NHS hospitals. So, I think to consider to sometimes stop from time to time and think what certain choices or actions, what their implications might be for energy use, or how much electricity is used. Um, I also I do think there are big structural problems. So I don't think we should put too much responsibility on the individual um, to 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 solve kind of like really big political and structural problems that we are facing.
Yeah,
Um, but I think to remember that systems are not only pipes and wires, but people are very much part of it as well, I think is a very, very good start. And that when changes are afoot to take the people who need to who experience those changes, who need to live those changes, and who need to implement the changes to take them along right from the beginning. I think that's a really big part of it, and that a lot of it comes down to the relationships between people, but also the relationships to the infrastructures, the buildings, and so on.
Yeah, I think you're right. I think it's really important, particularly if you're in estates management, to have a strategy to involve the people that are using the facility. It's very easy, as we said before. You can create some changes, but you're going to have knock-on effects to other things. And so, having everybody moving in the same direction to implement that change, particularly around energy use within the hospital, I think is really key. So I think that's a really good point to make, and to ensure that those people that are listening today really think about, when they go through the doors of a hospital, what is their impact, and what impact is that building having on them, and how can they address that from a sustainability point of view. I think that's really valuable. Nora, thank you so much for joining me today. I know we could go into so much more detail, and I hope you will come back onto the podcast at some point to talk again on this subject. But for today, thank you very much for joining me.
Thank you so much, Helen, and thank you for inviting me. And thank you for all those really interesting conversations that we keep having.